Welcome to the Medication Guidelines for Nurses online education module. This comprehensive module will take approximately 60 minutes to complete and is based on our practice support tool, Medication Guidelines for Nurses, that is located on our website. We would recommend that you follow along with the Medication Guidelines practice support tool as you view this online module. This 60-minute comprehensive module will cover the NSCN mandate, principles of medication administration, and principles of medication management, which include authority, competence, education, risk and safety, and collaboration. Additional information is provided when guidance related to the scope of practice differs among LPNs and RNs. Information specific to the role of nurse practitioners on prescribing medication or registered nurses authorized to prescribe is not discussed in this tool, except as it relates to providing guidance to nurses accepting medication orders written by NPs or an RN prescriber. Further information about the NP accountabilities for prescribing medications can be found in the Nurse Practitioner Standards of Practice, and further information about the RN prescribers' accountabilities for prescribing medications can be found in the RN-AP Standards of Practice. The Nova Scotia College of Nursing mandate is to serve and protect the public interest, preserve the integrity of the nursing profession, maintain public confidence in the ability of the nursing profession to regulate itself, and to set and monitor standards for the profession. There are approximately 15,000 nurses registered with NSCN that provide nursing services to Nova Scotians. This includes licensed practical nurses, registered nurses, and nurse practitioners. As the starting point, it is important that we review the definition of medication administration. Medication administration is the act of giving medications to an individual client through a specific medication route. Nurses are accountable to their clients to manage medication administration safely, competently, ethically, and compassionately. To fulfill this accountability, it is important that nurses consider these 5 principles related to medication management. Number 1, authority. 2, competence. 3, education. 4, risk and safety. And 5, collaboration. In the upcoming slides, we will be discussing each of these principles in further detail. Interwoven within these principles is the need for nurses to consider the most appropriate care provider to administer medications to clients. Determining the most appropriate care provider requires nurses to conduct a risk assessment. The 3-factor framework provides a guide to conduct this assessment. Nurses should consider the following factors: needs of the client, known versus unknown needs, if the care plan is established or not, predictability or consistency of client response. Secondly, supports in the practice environment. Accessibility of practice supports including authorizing mechanisms such as policies, procedures, and care directives. And thirdly, the individual nurse. A self-assessment of their individual competence, experience, and ability to manage outcomes. It is important for nurses to recognize that these 3 factors are interrelated and cannot be considered in isolation. Further information on the 3-factor framework can be found in the Nursing Scope of Practice Guideline on our NSCN website. It is important to note in LPN practice, there are no restrictions on the types of medications LPNs can administer. There are, however, certain contexts and clinical situations where LPNs may not be authorized to administer medication via a specific high-risk route. Some routes of administration, such as an IV or IV push, have a higher degree of risk associated because the potential for untoward outcomes is greater. High risk is associated with a greater potential for unpredictability, and therefore it may not be appropriate for the LPN to administer. The upcoming slides will individually review the principles of medication management that we touched on at the beginning of this module. These include the principles of authority, competence, education, risk and safety, and collaboration. Principle 1, authority. A nurse's authority to administer medication is granted through legislation, regulation, and policy. Nurses must be aware of and understand the scope of practice of the nursing profession, their individual scope of practice, and their scope of employment. Within this Principle 1, there are sub-principles which we will review on the next few slides. These include compliance with federal and provincial legislation, medication orders and authorized prescribers, and compounding and dispensing. Authority 1.1. Nurses must comply with federal and provincial legislation requirements for medication management. Prescribing, compounding, dispensing, and administering medications are activities that are defined in both federal and provincial legislation for specified health professionals. As a member of an interprofessional collaborative team, nurses should be aware of and understand the implications of relevant legislation, as well as the roles and responsibilities of each team member involved in the delivery of medications to clients. Appendix B, found in the Medication Guidelines for Nurses, contains examples of relevant legislation that impact medication administration. Please review these pieces of legislation. Authority 1.2. Nurses require an order from an authorized prescriber for all medications in Schedules 1 or 2 of the Drug Schedules Regulations made under the Nova Scotia Pharmacy Act. Authorized prescribers, medication orders, authorizing mechanisms, and over-the-counter medications and devices are components of 1.2 and will be discussed in the upcoming slides. To provide further information relating to the components of Authority 1.2, this first slide discusses those authorized prescribers in Nova Scotia that have the authority to prescribe, and they include NPs, RN prescribers, physicians, midwives, dentists, optometrists, and pharmacists. One of these prescribers may be less familiar, and this is the RN prescriber. These are registered nurses that have attained additional education and registration requirements to become a registered nurse authorized to prescribe. This gives them the authorization to prescribe medications within their specific area of prescribing competence and practice. The type of medication that individual authorized prescribers can prescribe varies depending on their professional designation, the schedule of drugs they are authorized to prescribe, and their scope of practice. Prescribers are accountable to know which medications they are authorized to prescribe. Nurses are authorized to take medication orders from all authorized prescribers, including nurse practitioners and RN prescribers. The second component of Authority 1.2 outlines the specifics relating to medication orders. A medication order is the direction provided by an authorized prescriber for a specific medication to be administered to a specific client. Medication orders may be received in writing or electronically, as well as delivered verbally in person or by telephone. A complete medication order must include the client's full name, date of order, medication name, frequency, strength, quantity, and concentration where applicable, route of administration, purpose for PRN medication, and the authorized prescriber's name, signature, and designation. When the order is intended for a client to use at home, the order must include the dosage with instructions including frequency, interval, or maximum daily dose, and how long the drug is to be used where applicable. The third component of Authority 1.2 is authorizing mechanisms. The types of authorizing mechanisms that are acceptable forms of medication orders include prescriptions, orders in the client record, care directives, pre-printed orders, and copy of a pharmacy telephone order. As we have just discussed on the third component of Authority 1.2, authorizing mechanisms slide, there are acceptable forms of medication orders. The first two types of authorizing mechanisms, prescriptions and orders in a client record, are familiar types across many practice settings. The use of a care directive, however, may not be as familiar for some practice settings. A care directive is an employer policy developed in consultation with an authorized prescriber for an intervention or series of interventions to be implemented by another care provider for a range of clients with identified health conditions or needs when specific circumstances exist. It is important to know the intervention must be within the scope of practice of the care provider implementing them. The authorized prescriber who writes the order holds the ultimate responsibility for the interventions, and to also see the Care Directives Practice Guideline found on our website, as well as employer policy for further guidance. A pre-printed order is a list of orders for a specific client for a specific health condition from which the authorized prescriber selects the applicable orders. Pre-printed orders must include the client's identifying information, include the signature of the authorized prescriber, and be included in the client's health record. When pre-printed orders are used, the client is first assessed by the authorized prescriber, who then selects the appropriate interventions from a set of pre-printed orders. These orders can be implemented as written unless the nurse determines a client-specific contraindication, such as an allergy. Appendix C in the Medication Guidelines for Nurses document provides guidance for a nurse to determine if an order is clear, complete, and appropriate. Over-the-counter medication and devices is the fourth component of Principle 1, Authority 1.2. Over-the-counter medications includes herbal medications or devices such as wound care or diabetic supplies. They do not require a prescription and are not part of the act of prescribing. As noted in the over-the-counter guidelines on our website, an employer policy must be in place authorizing the nurse to recommend or administer OTC medications or devices. Without a policy recommending or administering OTC medications or devices is not within the scope of employment of the nurse. Nurses should work with their employer to implement a policy enabling this practice if there is evidence clients would benefit from it. Employer policy on over-the-counter medications and devices is a requirement for LPNs and RNs. LPNs are authorized to recommend OTC medications or devices only in the limited specific context of advanced foot care practice as long as they have the competence to do so. In addition, there must be employer policy to support this practice. RNs may recommend and administer OTC medications or devices providing they have the knowledge, skill, and judgment to do so. The RN must ensure the recommended OTC medication or device is treating an already diagnosed condition and not a new symptom, which would require further assessment by an NP, RN prescriber, or medical practitioner. Nurses cannot personally gain from the promotion of any recommended OTC medications and devices as per the Nursing Act. Authority 1.3. Nurses do not compound or dispense medication. Compounding, dispensing, and drug samples are important components of 1.3 that will be covered in the upcoming slides. As noted on the previous slide, compounding is one of the components of Principle 1, Authority 1.3. Compounding involves the preparation of medication that contain individual ingredients that are mixed together in the exact strength and dosage form to meet the client's unique needs. Compounding is not within the scope of nursing practice. Crushing medications, reconstituting medications for parenteral administration, or mixing two different types of insulin are not considered compounding. As we noted, Authority 1.3 includes the component of dispensing. Dispensing is the interpretation, evaluation, and implementation of a prescription drug order, including the preparation, packaging, labeling, and delivery of a drug or device in an appropriately labeled container for administration and/or use by a client. Dispensing is not within the scope of nursing practice. Repackaging or providing medications after they have been dispensed by a pharmacy is considered supplying, not dispensing, and is within the nursing scope of practice. It is important to discuss what is not dispensing, as there are other situations that are often incorrectly referred to as dispensing. These include filling a mechanical aid or alternative container from a client's own blister pack or prescription bottle, repackaging and labeling drugs from a client's own supplies, administering medications prepared by a pharmacy, administering medications from a stock supply dispensed by a pharmacy, providing clients with their own blister packs or prescription bottles, providing clients with medications obtained from a ward stock or night cupboard, and providing medications from an agency pharmacy upon a client's discharge from an institution when they are unable to get their medications from their community pharmacy. These are all within the professional scope of practice of nursing as long as the nurse has the required competencies and follows employer policy. Additionally, drug samples are also one of the components of Authority 1.3 that we outlined. The Food and Drug Regulations permit the distribution of drug samples to and by most authorized prescribers. From a nursing perspective, it is important to understand our accountabilities, including employer policy is required to support NPs to distribute drug samples. LPNs and RNs can only distribute drug samples under an authorized prescriber's order or care directive, and agency policies pertaining to the distribution of drug samples should address their procurement, storage, access, distribution, and supply, as well as proper disposal. This second principle of medication management is competence. Nurses require knowledge, skill, and judgment in providing care for all of their clients. Within this principle, there are sub-principles that we will discuss, including nurses' competence to administer medications, nurses working within their legislated scope of practice, and documentation for all aspects of medication administration. Competence 2.1. Nurses are required to have the knowledge, skill, and judgment to safely administer medications. In the upcoming slides, we will discuss how competence applies to the accountabilities of nurses by discussing medication competencies, client focus, and medication rights. To begin with this competence section, we will start with the review of medication competencies that are necessary for nurses in order to safely and competently administer medications. Nurses need the knowledge, skills, and judgment to obtain a complete medication history from clients, including medication reconciliation. The medication reconciliation is a systematic process used to obtain a complete and accurate current list of a client's medication. For example, name, dose, frequency, route, which is then compared to a physician's admission, transfer, and discharge medication orders to identify and resolve any discrepancies. In addition, nurses require the knowledge, skill, and judgment to determine that each medication order is clear, accurate, current, and complete, and take appropriate action if clarification is needed. Nurses assess the appropriateness of a medication for a client considering the client's age, weight, pathophysiology, laboratory data, medication history, allergies, vital signs, and knowledge, beliefs about drugs. Nurses also discuss concerns about medication orders with the appropriate interprofessional team member in order to appropriately prepare and administer medications. Nurses need the knowledge, skill, and judgment to ensure medication orders are transcribed according to employer policy and have knowledge about the medication being administered, including therapeutic actions, possible risks, adverse effects, contraindications, and interactions with other substances. The required medication competencies also include nurses needing the knowledge, skills, and judgment to administer medications correctly, obtain informed consent before administering medications, monitor the effectiveness of medications, manage adverse reactions, consult with the appropriate care provider when client outcomes are not as expected or client needs exceed the scope of practice of the nurse, accurately document outcomes, and teach clients how to manage their own health, including medications. Our clients' healthcare needs are the driving factor of our work. It is important for nurses to identify the needs of the client, the supports in the practice environment, and the scope of practice of the individual nurse when determining who is the appropriate nurse to administer the specific medications. The Medication Guidelines for Nurses has a decision tree, Appendix A, to assist you in determining if you are the most appropriate nurse to administer a medication. Safe and competent medication administration requires the application of a safety framework or the 9 rights to the medication administration process and is one of the components of Competence 2.1. The 9 rights include right client, right medication, right route, right time, right dose, right reason, right response, right education, and right documentation. Competence 2.2. Nurses use their knowledge, skills, and judgment and work within their legislated scope of practice when implementing orders for medications which require nurses to determine doses and administration times. Within this principle, we will discuss PRN medications, range doses, and sliding scales and algorithms, and how nursing practice is provided by LPNs and RNs. PRN, or as-needed medications, are administered to clients following a comprehensive nursing assessment and are given only for the purpose for which they are ordered. An order for a PRN medication should include purpose of the medication and frequency with which it may be administered. Nurses are then responsible to monitor the client to determine the medication's effectiveness and document the outcomes. PRN medication orders must be administered as ordered. For example, if the order is for morphine 2 milligrams every 4 hours, the nurse cannot give 0.5 milligrams every hour. If the PRN order is not meeting the client's needs, the nurse must collaborate with the authorized prescriber and have the order reevaluated to ensure the client's needs are met. Range doses refer to medication orders in which the dose and frequency of medication is prescribed in a range. For example, acetaminophen 500 to 1000 milligrams PO Q4 to 6H as needed for pain. These range doses are often prescribed when a client's need for medication varies. Comprehensive client assessments are critical when administering range doses, including the client's response to previous doses of the medication. If the nurse determines the range dose prescribed is inadequate in meeting the client's needs, they should contact the authorized prescriber. Clear communication among clients, nurses, physicians, and pharmacists is vital for a range dose system to work effectively. Range doses have an important role in the medication needs of clients, and as such, the practice for LPNs and RNs caring for clients receiving range doses is important to highlight. LPN practice can be independent and collaborative, as we can see here in this table. For independent practice, LPNs are authorized to administer range doses as part of a well-established plan of care with readily anticipated outcomes based on a discussion with the client and using the effectiveness of any previous dosages as a reference point. Collaborative practice for LPNs occurs when the client's needs for a range dose is changed, becomes more frequent, or less effective. The LPN is expected to consult with the RN to collaboratively determine the range dose. In an RN's practice, they are authorized to administer range doses for clients in any context of practice as long as the RN possesses the required competencies. Some medications may be ordered according to a sliding scale or algorithm. These tools guide nurses in determining the dose of a medication based on a client's laboratory values or other parameters. Nurses must be aware of employer policy regarding the use of sliding scales and algorithms and ensure that these policies are current and based on evidence. Sliding scales and algorithms have an important role in meeting the medication needs of clients, and as such, the practice for LPNs and RNs caring for clients receiving medications that are on a sliding scale and follow an algorithm is important to highlight. The next 3 slides will review the practice for LPNs and RNs. LPN practice for sliding scale and algorithms can be independent, collaborative, and also not authorized. This slide and the next one will discuss how these 3 authorizations apply to LPN practice. We will start with independent practice. LPNs are authorized to administer medications using sliding scale and/or algorithms in the appropriate context, including where a baseline of assessment parameters has been established and documented in the client's plan of care. The algorithm is part of a well-established plan of care for a client whose outcomes are reasonably anticipated. The LPN has the appropriate knowledge, skill, and judgment, and LPNs are required to participate in employer-based education before they can engage in these skills. Sliding scale and algorithms from the collaborative and not authorized perspective entail these key points to note for LPN practice. Collaborative practice is in consultation with an RN and applies when the client's needs are not established, well known, or easily anticipated, or if findings in relation to the assessment parameters are unpredictable or frequently changing. In these circumstances, LPNs are expected to use the sliding scale or algorithm in consultation with an RN. Not authorized practice specifies that LPNs are not authorized to determine insulin correction or adjustment doses using protocols or care directives. For RN practice, RNs are authorized to administer medications using sliding scale and/or algorithms as long as they possess the required competencies. RNs should self-assess their competence and seek additional education if required. Additionally, the employer may require the RN to participate in employer-based education prior to engaging in these skills. Competence 2.3. Nurses document all aspects of medication administration. 2.3 includes competence regarding transcribing medication orders and documenting, which we will be discussing in the next slides. The first competence within 2.3 is transcribing medication orders. Transcribing is a process of transferring a prescriber's medication order from an order sheet to the medication administration record, also known as the MAR. When transcribing medication orders and determining the appropriate administration schedule, it is important to be aware of the accountabilities that are associated with this process. Nurses must apply professional judgment to maximize the therapeutic effect of the drug, support client choice, and comply with employer policy. In some practice settings, other individuals, such as ward clerks or other clerical staff, may participate in completing the paperwork involved in transcribing orders. Nurses are accountable for validating the accuracy and completeness of the transcription before the administration of medications to the client. Before administering the medication or medications, nurses are responsible to assess the medication appropriateness and verify that the medication orders, pharmacy labels, or medication administration records are accurate and complete, including the client's name and identification number, as well as the medication's name, strength, dose, route, timing, and frequency of administration as per employer policy. Transcribing medication orders is a collaborative practice for LPNs. LPNs are authorized to transcribe orders for medications they cannot administer, as long as they can administer the medication via another route. For example, IV metoprolol, an LPN may not be authorized to administer the metoprolol intravenously, but can give it orally and therefore can transcribe the order. In these cases, the LPN is accountable to make sure the transcription is verified by an RN. Documentation of medication administration usually takes place in the medication administration record, but could also be within the notes section of the client record. Nurses are accountable for ensuring timely, accurate documentation of all medications they administer. All documentation of medication administration should include client's name, name of the drug or drugs, date and time of administration, dose, route, site if applicable, and the nurse's signature designation as per employer policy. Nurses are required to document any adverse reactions to medication, the client's response, any related interventions, and information provided to a client in communication with other members of the healthcare team. For further information, please refer to the Documentation Guidelines for Nurses Practice Guideline and the Employer Policy. Documenting medications administered by others includes emergencies, self-medication, and nursing students. We'll start with emergencies. Nurses should only document medications that they have personally administered and should not permit anyone else to document for them except in an emergency. For example, in a cardiac arrest, a healthcare provider is usually designated to record all medications given by team members. However, the healthcare providers who actually administer the medications should countersign this record as soon as possible after the event. In self-medication circumstances, in certain care contexts, clients may self-administer medications. However, as a nurse caring for the client, the nurse maintains responsibility for monitoring and documenting the client's medication usage, and employer policies should be in place to support this practice. For students, when we're working with nursing students, nurses should be knowledgeable about policies pertaining to the administration of medications by them, including any restrictions placed on students' practice. The nursing student should document in the medication administration record, and the entry should not be cosigned as this blurs the lines of accountability. No further documentation is required by the nurse unless dictated by employer policy. Principle 3, Education. Nurses are required to continue to seek knowledge. We will review in the upcoming slides the additional components within Principle 3. These include non-traditional medications and nurses seeking assistance and knowledge as needed when they identify a gap. Education 3.1. Nurses seek knowledge when administering non-traditional medications. This is part of the first component of education and includes gaining knowledge related to complementary and alternative medications, investigational medications, restricted, non-formulary, and special access medications, or emergency release medications, and off-label use of medications. Over the next few slides, we will discuss each of these aspects individually. As we noted during the previous slide, each of the components of education in 3.1 regarding nurses seeking knowledge when administering non-traditional medications includes complementary and alternative medications. Before administering complementary and alternative medications or providing advice about their use, nurses must have a prescription from an authorized prescriber and be knowledgeable about the therapeutic benefits, side effects, contraindications, and potential interactions with other prescribed medications. Further information on nurses' roles and responsibilities in relation to complementary and alternative medications are outlined in the Complementary and Alternative Healthcare, a guideline for nurses that can be found on our website. This second component of Education 3.1 is investigational medications. Investigational medications are used in human clinical trials and must be approved by an independent research ethics board. These medications require an order and additional written consent, the process for which must be outlined in the research protocol. LPN practice is collaborative in caring for clients that are receiving investigational medications. LPNs are authorized to administer Phase 3 investigational medications administered via the PO, IM, or sub-Q route, but not via the IV route. Employers and LPNs wishing to engage in practice must consult an NSCN practice consultant for guidance in developing policies and processes. In an RN practice, RNs may only administer investigational medications to those clients involved in the clinical trial, are accountable to apply the principles of safe medication administration, including carefully monitoring client outcomes and documenting relevant findings as outlined in the research protocol. This third component within 3.1 includes restricted, non-formulary, and special access medications or emergency release medications. Nurses may be requested to administer these types of medications, and it is important to have an understanding of these definitions. Restricted medications are formulary medications that are restricted for a specific indication or specialty. Non-formulary medications are not on an employer's formulary or approved for general use and require special authorization. Special access medications are only authorized through the Special Access Program of Health Canada for use in serious or life-threatening conditions for which conventional therapies have failed or are unsuitable or unavailable. Restricted non-formulary and special access medications, emergency release medications, are within the scope of practice for nurses. However, it is important to understand the practice context that is applicable for nurses. For LPN practice, this includes collaborative and not authorized application, meaning in the collaborative context, LPNs may administer restricted and non-formulary medications when the administration of the medication is part of an established plan of care with clear and predictable client outcomes. In the non-authorized context, LPNs are not authorized to administer special access emergency release medications. In the context of RN practice, RNs are required to have an order and a signed and dated client consent form before administering any restricted, non-formulary, or special access medications. This fourth component of education is off-label use of medications. Off-label use of medications refers to the practice of using a Health Canada approved drug for a purpose that is not indicated by the manufacturer, but has been deemed potentially beneficial by the prescriber for a client. Off-label use of medications has accountabilities for nurses. Nurses should be knowledgeable about the scientific rationale for the off-label use of a medication as well as the possible side effects. Prior to administering an off-label medication, nurses may need to speak with a prescriber or a pharmacist if there are any questions or concerns. Nurses should also communicate to the client the reason for the off-label use of a medication and associated risks. LPN practice is collaborative for the off-label use of medications, and as such, LPNs are required to collaborate with the RN when administering medications for an off-label use. Education 3.2. Nurses know the limits of their knowledge, skills, and judgment and seek assistance and additional knowledge as needed. 3.2 includes procedural sedation and analgesia, patient-controlled analgesia, and immunizations. We will discuss each of these individually over the next few slides. This first component of 3.2, procedural sedation and analgesia, PSA, will review nursing practice for LPNs and RNs. PSA is used to control pain or psychological stress during procedures such as suturing or cast application. Clients receiving PSA have a slightly depressed level of consciousness and are usually able to maintain their airway and respond appropriately to verbal commands and physical stimulation. LPN practice is collaborative and also not authorized. It is important to understand this distinction. LPN collaborative practice entails LPNs being authorized in specific and limited contexts to administer oral, rectal, or injected sedation medication. Employers and LPNs wishing to engage in this limited practice should consult an NSCN practice consultant for guidance in developing policies and processes. The employer may require LPNs to participate in employer-based education prior to engaging in these skills. LPN not authorized practice entails LPNs not being authorized to administer IV sedation or medications intended for the purpose of general anesthesia. RN practice is autonomous. RNs are authorized to administer PSA via any route as long as they possess the required competencies and it is supported by employer policy. RNs should self-assess their competence and seek additional education if required. The employer may require the RN to participate in employer-based education prior to engaging in these skills. The third component of 3.2 is immunizations. Vaccines have a significant positive impact on the health of the population by controlling the spread of vaccine-preventable disease. Administering immunizations safely, competently, and ethically requires additional knowledge, skills, and judgment. LPN practice is independent and collaborative for immunization. In independent practice, LPNs are authorized to administer immunizations as long as they possess the required competencies. LPNs should self-assess their competence and seek additional education if required. The employer may require the LPN to participate in employer-based education prior to engaging in these skills. For collaborative practice, LPN should consult, collaborate, or refer clients to an appropriate care provider before administering the vaccine for clients with an increased risk of a negative outcome. For example, client with a history of reaction to immunizations. Further information on immunizations can be found in our Immunization Practice Guideline. In the context of RN practice, RNs are authorized to administer immunizations as long as they possess the required competencies. RNs should self-assess their competence and seek additional education if required. The employer may require the RN to participate in employer-based education prior to engaging in these skills. Further information on immunization can be found in the Immunization Practice Guideline on our website. Principle 4. Risks and Safety. All nurses assess the risk and safety aspects in their practice context as one of the components of care for their clients. The upcoming slides encompass a number of components in relation to this risk and safety principle, including verbal orders in emergent or urgent situations, use of employer-approved abbreviations, pre-pouring medications recommendations, handling, storing, and transporting controlled drugs and substances, and actions to resolve or minimize the risk of harm to clients from medication errors or adverse reactions. As we have been doing with the previous components of each principle, we will be reviewing each of these individual components for risk and safety in the upcoming slides. Risk and Safety 4.1. Nurses only accept verbal orders in emergent or urgent situations. These next few slides will provide information regarding orders and the nursing role related to ensuring verbal orders are completed in the proper manner. Verbal and telephone orders have important components to consider for the authorized prescriber and the nurse. Authorized prescribers should write medication orders whenever possible and review and countersign verbal or telephone orders within the time frame indicated in the employer policy. Nurses can accept verbal or telephone orders from authorized prescribers when it is in the best interest of a client and there are no reasonable alternatives, such as during an urgent or emergent situation. Due to a higher risk of medication errors associated with verbal or telephone orders, the nurse must communicate clearly and document the conversation with the prescriber in a timely manner. When taking a verbal or telephone order, nurses should ensure all elements of a medication order are included and note the time and date of the conversation. Nurses should read the order back to the prescriber to confirm accuracy and sign the entry as per employer policy. Nurses should indicate on the order form that the verbal or telephone orders were read back to the prescriber when possible, and document their nursing assessment, actions taken, and any client outcomes associated with the order. LPN practice includes independent and non-authorized components in regards to verbal and telephone orders. Independent practice includes when there is an occasional requirement to take a telephone order for a medication via a route that an LPN cannot administer because it is not part of their individual scope of practice or scope of employment. The LPN in those situations may take the telephone order as long as they are competent to administer the medication in a different route. Non-authorized practice for verbal and telephone orders are specific and include LPNs not authorized to take telephone or verbal orders for intravenous chemotherapy, sedation, or PCA epidural pain medication. There are no specific parameters for RN practice other than the general guidance provided for all nurses in the previous two slides. Using technology to transmit medication orders is becoming more commonplace. Faxes, emails, smartphones, and other wireless devices are now frequently being used to communicate client information in healthcare settings. All information transmitted electronically, such as orders sent by fax or email, are considered part of the client record. Nurses are accountable to verify the appropriateness of a faxed or electronically transmitted order in the same manner as they would for all orders by following employer policy. Nurses should be aware of and follow employer policies for transmitting client information electronically, such as the use of encryption software, user verification, or secure point-to-point connections. If the employer does not have a policy on the use of technology, you should not accept orders in this manner. Orders received via text messaging, social media sites, and or sent to a nurse's personal email account are not acceptable. For more information on text messaging, please see the Documentation Guidelines for Nurses and the Social Media Practice Guideline on our website. Risk and Safety 4.2. The use of abbreviations in the medication process can be hazardous to client safety due to the risk of errors occurring when prescriptions or medication orders are written, transcribed, or read. You should only use abbreviations that are approved by the employer, and you have the responsibility to know the approved abbreviations. Risk and Safety 4.3. Pre-pouring of medications occurs when one nurse prepares a medication but does not administer it immediately or has another nurse administer it. Nurses should not pre-pour medications, as this practice increases the risk of errors and blurs the lines of accountability. In the upcoming slides, we will review pre-pouring as it relates to emergency situations, immunization clinics, and client self-administration. Pre-pouring medications may occur in emergency situations in which more than one healthcare professional is required to assist in medication administration. For example, in the event of a cardiac arrest, one nurse may prepare and label medications while another nurse or authorized health professional may administer them. In these situations, both the nurse preparing the medications and the nurse administering the medication would be required to document the medication administration in the client's health record. Employer policies should support this practice and further define accountabilities. Pre-pouring medications may occur in immunization clinics. Specifically, in the practice context of an immunization clinic, it may be acceptable for the nurse to prepare multiple doses of vaccine to be administered by multiple nurses. This practice is specific and limited to certain circumstances and must be supported by employer policy. Nurses should be familiar with the employer's policy specific to mass preparation of medications. In some contexts, it may be appropriate for the nurse to pre-pour medications to be self-administered by the client over time. This may include filling a mechanical aid or alternative container from a client's own blister pack or prescription bottle to facilitate self-administration. Risk and Safety 4.4. Nurses utilize evidence-informed practice when handling, storing, and transporting controlled drugs and substances. The upcoming slides will review federal legislation and regulations and community practice and transportation of controlled drugs and substances. Federal legislation and regulations through the Controlled Drugs and Substances Act and the Narcotic Control Regulations establish requirements for the appropriate handling, storing, and transporting of controlled drugs and substances. Employer policies must be established to support these requirements, such as who can receive the delivery of controlled drugs, who can access locked medication storage cabinets, who can perform controlled drug counts, how to document drug counts, and how to manage discrepancies. In most facilities, nurses are authorized to receive the delivery of controlled drugs, access locked medication storage cabinets, and perform controlled drug counts. Appendix B in the Medication Guidelines for Nurses that you have been following along with in this module provides a brief overview and definition of the federal and provincial legislation. While federal regulations stipulate requirements for management of controlled drugs and substances in healthcare facilities, these same regulations do not apply to controlled drugs and substances in the client's home. Because there is a potential for diversion of controlled drugs and substances, nurses should educate the client and family on safe storage and disposal of any prescribed controlled drugs in their possession. This could include advising clients to keep only the minimum amount of their controlled drug in the home, requesting a smaller supply from their provider or pharmacist, ensuring medications are stored safely out of sight, preferably in a locked box or cupboard, avoiding discussion about the controlled drug being present in the home when in public spaces, and advising clients to return any controlled drugs that are no longer required to a pharmacy for proper disposal. In September 2018, Health Canada issued Section 56 class exemptions authorizing nurses practicing in community settings to transport controlled drugs and substances. Under the Controlled Drugs and Substance Act and its regulations, nurses, other than nurse practitioners, can only conduct activities with controlled substances if they have been prescribed by a practitioner and they are employees of a hospital. Health Canada recognized that nurses are often responsible for primary care in the community, and therefore, within this context, nurses often conduct activities with controlled substances. These exemptions authorize nurses to possess, provide, administer, transport, send, and deliver controlled substances while providing healthcare services at community health facilities under certain conditions. The exemptions can be viewed in further detail by following the link found on page 15 on the Medication Guidelines for Nurses document that you have been following along throughout this module. In addition, the exemption allows nurses working at community health facilities to transport and provide controlled substances prescribed by a practitioner to the client. Nurses should work with their employer to determine if their facility qualifies under these exemptions. Risk and Safety 4.5. Nurses take action to resolve or minimize risk of harm to clients from medication errors or adverse reactions. There are a number of components that are within 4.5 that we will review individually in the upcoming slides, including medication errors, medication error factors, collaboration and errors, examples of organizational strategies to support nursing practice, reporting errors, and independent double check. The first component that we will discuss is medication errors. Medication errors are preventable events related to incorrect administration of medications that pose a risk to client safety. An error may occur when medication is not administered according to the 9 rights, and if medication is improperly reconstituted or administered despite knowledge of contraindications or a medication allergy. Some examples of medication errors include a near miss. That is an event, situation, or error that could have resulted in unwanted consequences but did not occur because either by chance or through timely intervention, the event did not reach a client. The second is a no harm incident, and that is a situation where the medication was administered to the client but no discernible harm occurred. There are many factors that can lead to medication errors that we need to be cognizant of, and these include provider fatigue, inattention and/or distraction, workload and time pressures, ineffective verbal and written communication between healthcare team members, packaging and dispensing errors, borrowed medications, and insufficient knowledge. Nurses and healthcare employers must work collaboratively to identify system and individual risk factors, to indicate proactive measures to decrease error situations, to report all errors, no harm, and near misses, and to intervene to minimize the potential for client health to be compromised as a result of medication errors. There are many organizational strategies in place to support quality medication administration practice. Some examples include 24-hour access to current medication administration resources, such as CPS, implementation of scheduled maintenance processes for equipment used in the administration of medications, for example, IV pumps, provision of an appropriate environment for nurses to prepare medications, provisions of uninterrupted time for nurses to administer medications, provision of sufficient support and continuing education opportunities for nurses to further develop their competencies related to pharmacology, and integration of information related to medication systems within orientation programs for new employees. When medication errors occur, immediate steps should be taken to safeguard clients, resolve issues, and inform the client and family. A supportive, no-blame culture encourages inter- and interprofessional dialogue, reflection, problem analysis, and the development of preventative strategies. The facts of a medication error must be documented in a client's health record, including medication that was incorrectly administered, client assessment and status, corrective actions taken to safeguard the client, and follow-up monitoring. Employer-specific forms such as incident or occurrence reports may also be required in the event of an error, near miss, or no harm incident. However, the fact that an incident report was completed should not be documented in a client's health record, and copies of these reports should not be added to the client health record. Employer policy should be followed when responding to and documenting the error. Anyone involved in a medication error may be asked to participate in an employer's quality improvement review, which is conducted to improve client care and reduce future risks. Nurses in formal and informal leadership roles may also be asked to participate in quality improvement initiatives aimed at preventing medication errors. The Institute for Safe Medication Practices in Canada recommends conducting independent double checks with high-risk processes, such as preparations that require complex calculations and high-alert drugs. An independent double check is a process in which a second practitioner conducts a verification of the medication and/or calculations. The verification can be performed in the presence or absence of the first practitioner. However, the critical aspect is to emphasize the independence of the double check by ensuring that the first practitioner does not communicate to the second practitioner what they would expect the second practitioner to see. Some employers have established a policy that requires nurses to perform double checks of certain medications with another colleague prior to administration. Nurses are accountable to know, understand, and follow their employer policies relating to double checking and high-risk medications. Principle 5. Collaboration. Collaboration is central to the profession and is one of the key components of medication administration. In the upcoming slides, we will individually review the components that are within this principle, as we have done throughout this module. Collaboration 5.1. Consultation when orders are unclear and require clarification. Nurses are accountable to take action if orders are unclear. This requires a nurse to assess the medication order to determine if it is legible, accurate, current, and complete. If the order is not clear, the nurse must consult with the authorized prescriber who ordered the medication or another appropriate healthcare provider. The decision tree and Appendix A in the Medication Guidelines for Nurses document that you have been following along throughout this module will assist nurses with decision-making related to clarification of giving a medication. Collaboration 5.2. Nurses collaborate with clients in the management of their medications. In the upcoming slides, we will review collaboration as it relates to informed consent, covert medication administration, medications from home, and placebos. Clients have the right to make decisions about accepting or refusing a medication or to self-administer medications. Nurses should verify informed consent with the client before administering medications. Informed consent can be recorded formally, such as on a consent form, stated verbally, or can be implied. For example, the client holds out their arm for an injection. Policy and procedures for obtaining informed consent from the client should be developed and implemented based on best practices and applicable legislation. In a situation where a client refuses a medication, nurses are expected to determine the reasons for a refusal, assess the client's level of understanding about the medication's effects, document, and follow up with the prescriber as appropriate using nursing judgment. In situations where there is concern or question about a client's capacity to consent, nurses should consult with the appropriate healthcare provider to determine the appropriate action. Further information on capacity can be found in the Assessing Capacity Practice Guideline on our website. This guideline may be helpful to review. Covert medication administration is the practice of administering medications to a client without their knowledge or consent. Nurses' accountabilities related to covert medication administration includes: nurses are accountable to ensure a client is aware of the medication that is being administered to them. When a client has made an informed choice not to take a medication, it should be withheld and the prescriber should be informed. If it has been determined that a client does not have capacity to make an informed choice about their medications, the substitute decision maker will make the choice on the client's behalf. Nurses must be aware of provincial legislation such as the Adult Capacity and Decision-Making Act and/or the Personal Directives Act that are related to the role of substitute decision makers in client care and employer policies. In some settings, such as summer camps, respite care, or shelters, clients often bring their prescription and over-the-counter medications from home and expect the nurse to administer them. Whenever possible, clients should be encouraged to self-administer these medications. If nurses are required to administer them, there should be an employer policy to support this practice. There must be an approved order from an appropriate prescriber, and the medications must be in their original containers and appropriately labeled within a fixed prescription label. If there is a discrepancy between the prescription label and the administration directions from a client or family, the nurse must clarify the order with the authorized prescriber. When clients bring prescription and over-the-counter medications into a healthcare facility, nurses must follow employer policy related to the use of these medications. A placebo may be administered when its use has been discussed with the client involved, informed consent has been acknowledged, and the client's signature has been received and witnessed. The administration of placebos to clients without their knowledge and consent is inappropriate and unethical. When clients are participating in a placebo-controlled study, they should understand their chance of receiving a placebo versus the investigational drug. Intentionally withholding information regarding placebo use denies clients the opportunity to make their own decisions. Collaboration 5.3. Nurses appropriately assign and supervise medication management when unregulated care providers are part of the care team. It is important to be knowledgeable about the role of unregulated care providers and our accountabilities as nurses. Unregulated care providers can be employed in a variety of contexts of practice and perform client care activities under the supervision of professional nursing staff. Many of the care activities performed by unregulated care providers in these settings involve assisting clients with performing activities such as bathing, mobilizing, and feeding. Some of the care activities performed by unregulated care providers may also include assisting clients with the administration of some medications. Unregulated care providers can be delegated or assigned the application of medicated creams and ointments, both prescription and over-the-counter. The unregulated care provider is accountable to apply the cream or ointment as prescribed, document the application, and collaborate with the nurse. In these settings, the nurse retains the accountability to assess the client to determine the appropriateness and effectiveness of the medication within the established plan of care, due to unregulated care providers not having the knowledge to perform a comprehensive client assessment. Nurses should be aware of employer policy with respect to unregulated care providers assisting with medication administration or the application of medicated creams and ointments, including documentation. Thank you for participating in this online education module. The Medication Guidelines for Nurses document that has been used in this module can be readily found on our website. We encourage you to reach out to the practice team should you have any questions related to medication administration and your nursing practice.